Ready to go. All right, and we'll hit record. Okay, guys, so sorry about that delay. Happy to see so many people here. I see a lot of familiar names. Gosh, I kind of don't like this webinar format either because it's just me. I do like the a little bit more interaction, but you guys can populate the chat. If you all want to make me feel awesome, populate the chat, guys, so that I feel like I'm not here alone. Because for me, I get it's this one little screen. So I am going to, I'm going to be talking about heart health, and I'm going to bring up my PowerPoint here in a second, and we're going to get started. So, but interact as much as you guys can, guys, because I love the interaction. It helps me, and I'm selfish. I'm being a little selfish here, but I like the interaction. I like questions. I like people interrupting. I may even, call you up to come here and interact with me. All right, so let me share my screen, and we will get started in a second. I'm going to go to the slideshow, and then I have to figure out how to share the screen. Okay, here we are. Share screen. Here we go, share. And here we are. Okay, so can you guys see the screen? Give me like a big thumbs up if you guys can all see the screen. Okay, and I'm going to bring the chat up here so you can see the slides. Okay, perfect. Can you see the chat too, or is that like something that's hidden? You guys can see the chat. Okay, and it's annotating me here, so that's really cool. And we got somebody raising their hand, so this is really cool. All right, so guys, welcome. If you're on social media and joining us because you want to learn about heart health, or if you're on the Toward Health app joining us, or if you're a patient and just sort of getting access to this, I'm grateful for you all being here, grateful for your all support and your interest. I think this is a really important topic. Remember, heart health is the number one killer, right? It is the number one killer, and it's one of the least screened modalities. Everybody does a colonoscopy, everybody does a mammogram. Everybody's interested in screening, for for colon cancer or breast cancer, or maybe they're getting a PSA. But it's so surprising to me how little we do, heart health screening and cardiac screening. Less than 1% of people will ever get a cardiac screen, which I think is such a missed opportunity. So I'm excited to talk to you all about this, especially because it is Heart Health Month. So here's my disclosures. Who I am. My name is Dr. Tro Kalayjian. Many people don't know they know I'm an internist. Maybe they know I'm an obesity medicine doctor. I'm actually a certified personal trainer too. I'm proud of that. One. I'm also a certified health coach. I'm on the board of the SMHP, the Society of Metabolic Health Practitioners. I'm also part of the Coalition of Metabolic Health. I like to work with not-for-profits that are looking to make a difference in our lives. In the lives of people with metabolic disease is very important to me. I like to run and exercise. I've helped over 2,000 patients here in our clinic, and we have a smartphone app with now 16,000 members. So if you're new, if you're not, you're just coming to me, go download the Toward Health app. It's got live courses you can go to, anytime. There's a fasting course going all through this month, guys. So if you're coming to this for heart health, we have a free fasting course you can pop into with Tia and Vic. And we always have something every month that you can hop into, and we're looking for ways to make it more engaging. So go download the Toward Health app. I publish papers because I'm a little bit of a, I just want to, I want to spread what it means to be a good doctor. I want to create a system of a practice and a system that makes doctors want to be more excellent than the current system. And so I'm very passionate. I know I'm opinionated, and some people, I would say don't even follow me on social media, but I can be a little adversarial at times, but I will say I'm passionate about this cause. I've seen my family suffer, and I've suffered, and I do want to see medicine do better and be better, to the point where I've called out the hypocrisy of the National Lipid Association and the AAP in the scientific journal. And that's my amazing wife, and my disclosure to make. My amazing wife is, she's a food company, so a low-carb food company nonetheless, so that's my disclosure. I have three, you may not all know this, but I have 3 IRB projects with, right now, one with Stanford that is pretty much wrapped up, one ongoing with Yale New Haven, and another with Wake Forest. So this is what your support does. We take your support, we go and we try to bring things to the literature, we work on research, we advocate as best as we can to improve medical care and metabolic care. And I have to disclose this because this is not yet fully announced. But we are the recipient of a grant from the Bazooki Foundation. Okay, so what are we talking about here? We're talking about what drives plaque, right? Including insulin resistance, inflammation, endothelial function. We're going to be talking about all of it, and we're going to be talking about some of the clinical trials around what stabilizes and in some cases been shown to reverse plaque. Yes, reverse plaque. I just said reverse plaque, and I'm going to say it again. Reverse plaque. You can reverse plaque. So it doesn't always mean reverse calcification. It means reverse plaque. Okay, so we will talk about that. We're going to talk about the importance of a individualized approach and what we do in our clinic, and we're going to talk to you about the new AHA calculator. I'm going to run through a lot of this, and I'm going to try to focus on, because there's a lot to do here. This is going to be an hour. It may even be more than an hour, so I'm just going to warn you that this may go over. I want to give a special thanks to the Society of Metabolic Health Practitioners and the Coalition for Metabolic Health. These are 2 not-for-profits that I work with and I'm happy to volunteer with. And I was so happy when we flipped the pyramid upside down. And this is me at HHS when this policy was announced, which I was so happy to be a part of. Yes, this will be on replay. So this was a proud moment for me because, and here I am with like 2 of the giants for me, David Ludwig, who's been a mentor, and Gary Taubes, who's always been so kind to me, and they're both huge pioneers in this field. And another person who wasn't there, and I want to just thank, because I have a moment, Dr. Eric Westman, who's been a mentor to me for the past 8 years. It's their hard work, and I want to put out the work of Nina Teicholz specifically, that really made this flipping of the pyramid possible, which I'm so proud about. I think it's what a culminating moment. There's some problems with it, certainly, but it's a step in the right direction, and we're going to keep going further. We're going to go out to the schools and the hospitals and the medical schools and the universities and explain to them what proper nutrition is and how important it is to flip that pyramid. So just a quick little preamble. So let's be detectives together. I think this is let's bring our curiosity back to metabolic health. This is obesity in the United States over the past several decades, right? 1985, it's not quite there. 2008, it's really growing. 2016, it's really becoming a dual pandemic of obesity and diabetes. And what happened at those times, and this is just a correlation, but this is the food pyramid, and this is the my pyramid, and then this was the my plate that happened at those times. And could it be that our food is directly linked to obesity? I mean, could that be the case? Our guidelines being part of the problem here in our nutritional approaches. So let's be detectives. Is that what the issue is? And here is, obesity over the past several decades. I've showed you all this before. And you can see it kind of spreads like a contagious disease. It starts in the Midwest and just spreads out. And it eventually gets to everybody, right? But and it feels like a communicable disease when you look at it over, decades. And if you look at, this map of obesity, it lines up with things that shouldn't line up. Why is obesity matching up exactly with arthritis? Why is it matching up exactly with a blood sugar issue? Why is it matching up exactly with mental health distress? I mean, exactly like mental health distress. Why is it matching up with sleep duration, with heart disease, with cancer? How are cancer and heart disease related, right? Like, what is it that's spreading like a communicable disease and spreading throughout our nation to the point where now we have a 20% fatty liver epidemic in our children, and a 30% prediabetes rate in our children. So are we thinking about this? And this is a very important, video that I want you to watch. Hopefully you all can hear it. But this is, I'm going to pause it because I don't know if you can hear or not. Give me a thumbs up if you can hear it, guys. Remember, I said you got to interact with me or I'm leaving here. You gotta write in something in the comments or in the chat. All right, so you can hear it. So somebody say, yes, we can hear this, Okay. But this is the Framingham study, and this is the Framingham study over decades. And what you see here, the dots are people with obesity, and what you see here, the yellow dots, and the green dots are people who do not have obesity. And you're going to see what happens over decades. I'm going to press play here. So let's actually go back and be detectives together here. So you could see here, I'm going to start decades earlier in the Framingham data set, obesity was kind of rare. And then if you fast forward, it becomes over-dominating. And it spreads from person to person, right, in like a social virus, right? And the point of this is, and if you think about it, well, what is happening? How do you explain it? It's most certainly not an actual virus, right? Although there's some people who think that there are some viruses that predispose you to obesity or to diabetes. But, what if this is actually our food habits being transferred from person to person? What if these clusters are our families and our friends and our coworkers? Right? And what about these thin clusters here that are getting maintained throughout this study? That thin cluster there, what if that's the people in this room right now? The people who are learning about metabolic health and trying to reverse chronic disease, and then they're trying to take that back to their community. So you're preserving health in your community, right? Your bubble, your family, your friends. I'm sure they're all so tired of hearing you talk about keto or CrossFit or whatever it is, but that's what that is. That's this community here, and that's maybe the CrossFit gym or the F75 that you go to, or that's what this is. So if you look at it, what explains this, right? And it's most likely, the current idea of how do we explain chronic disease is very hard for the average doc to explain this. They don't understand. We all kind of know it because our kids are getting it at a very young age, and everybody's had it, and it's spread like a social fire. So if you could put one word in the chat, I want you to know what explains modern chronic disease. I'm just curious to see what everybody thinks. And I'll tell you what I think. This is the modern disease, epidemic and metabolic disease, and it's spread to so many things: obesity, stroke, heart disease, fatty liver, dyslipidemia, right? Sarcopenia, arthritis, migraines. We all know that these are tied to metabolic disease. And the costs of the modern medicine, it's astronomical how much we're spending on each one of these diseases and the suffering, right? So not only are we suffering, but the mental, the financial, and like the physical and spiritual toll are so great, right? And yet we're all kind of accepted it, and our doctors have accepted it, and this is, this needs to change. We're all here in this room. We're all following me on wherever you're following this lecture, because we all know it needs to change. Because the alternative is we go bankrupt as a nation. If you're like an HR leader right now, I know you care about this because you're seeing your premiums go up. And if you look at the roots of this problem, it's poor sleep, duration and quality, cellular stress. And I want to put psychological stress here too. And the big one, what I'd say 70% of it is insulin resistance, but also chronic inflammation, the tooth abscess you didn't take care of, the skin infection you didn't take care of, the chronic UTIs you get, and also modern pollutants and contaminants, which we really take for granted. The heavy metals, found in your plant proteins that we've just accepted, and the microplastics we've all accepted. So, and the margarine instead of butter. Yes, it's the insulin resistance that is largely driving this. And if you ask me, and this is just, this is a graph here of the prevalence of these problems. 88% of people have metabolic dysfunction and insulin resistance, maybe more. 40% have poor sleep quality, chronic inflammation. 30 to 40% will have an elevated CRP. And these are all the, the references to describe each one of these. 60% of people in America have moderate, to high stress. I mean, it's astronomical. We take for granted the impact that does to our bodies. But, I quantified these here, as a population. I just gave it my subjective, health impact. I think in my clinical experience, 70% of the problem is diet, but do not discount the rest of these. They're so important, and namely sleep. It's probably the most one, and psychological stress. It's so important for overall health. But this is what's driving our disease, and I don't need to tell you guys. You guys know. You're hearing me lecture. I just want you to know. A lot of the what you're about to hear is this entire team and what we've done over the last nearly a decade. With a big thank you to Laura and Talene, who Talene is our office manager, our operations manager, and she's just been an absolute beast. So hopefully somebody send a clip of this and send it to Talene, because she is so invaluable to making sure everybody gets healthy in this practice. And to Laura for taking a chance on me and sticking around for so long and working so well together. So big thank you, but thank you to everybody on our team. And I'm going to blow through these. We've published on our results in reversing this chronic disease epidemic. We published, the average person in an employee wellness cohort losing 38 pounds, dropping A1C by 1.1, blood pressure 17. We recently, last year, we published a study with 50 patients where we stopped about 2 medications each, and average weight loss was 43 pounds. And this is head-to-head how Toward Health did with the label results of Wegovy. So you can see that lifestyle could be as nearly as impactful as medications, and in some cases maybe more impactful. And don't discount the improvements in mental health you get by improving what you eat. And this is a study we published showing the Toward method improving binge eating symptoms and food addiction symptoms. I'm going to blow through these because you guys all know about Toward Health and what we do, so I'm not going to talk about it. Basically, coaches, clinicians, support groups like this one. So give me a thumbs up if you like support groups and lectures like this, like being done in a community style where we bring people together to try to educate and support. Being able to access your clinical team 24/7, getting frequent blood tests and remote monitoring to keep you on track. So before I get into the specifics of heart health, talking about the Cleerly test, the CAC test. Here's our cardiovascular data, and this is not published, so just, this is not peer reviewed yet. We're gonna, this is mean results, not median results. So just take all this. It's 120 patients in our practice, and we did what the AHA wanted us to do. They said, go do the PREVENT calculator, which is a 3-in-1 calculator they just released, looking at the chance of having a heart attack, stroke, or heart failure. We did the test that they asked, and you can see here the little devil sign that came up here on the AHA thing. So if you didn't see it, I'm going to do it one more time. You all see the devil come up on the AHA thing because they take corporate sponsors. That's why there's a devil thing. The canola industry sponsors them. So we did what they asked, okay? So I'm going to do it one more time in case you didn't catch it. But we did what they asked. This is the calculator they want us to do, where it looks at your sex, whether you smoke, what medications you're on, your age, your cholesterol, your blood pressure, your kidney function, your diabetes status, your A1C, your zip code. And it comes up with a risk. And so we calculated a cohort's risk before the intervention. Their 10-year risk of having a cardiovascular disease was 7.3%, and after our program it was 3.8%, which is a 48% reduction. And this was a mean score, and the median score was a little bit less, and we'll be sharing that in a publication. And we looked at just atherosclerosis specifically, and the numbers are very close, and heart failure was a whopping 63% decrease in the relative risk reduction. The absolute was 3.9%. And this is doing what you all know to do, which is put metabolic health first in an evidence-based fashion. And a big part of this, I think, is the curriculum that's in our app, which I'm going to go through with you right now in, around heart disease. We have educated people on how to get screened in a course very similar to this, and we gave them evidence-based info on how to reduce their cardiovascular risk, and we have helped them, our patients, implement lifestyle change. So this is what I think is how you should look at atherosclerosis. Like, how is it? First of all, atherosclerosis, just so you all know, we make this so hard. Doctors want to use big words to justify their $50,000 a year tuition. We are literally talking about pipes that feed oxygen via blood to your muscles and to your tissue. And that's the cardiac arteries. You have these coronary arteries, right? The right coronary artery, the left main, and which breaks off into the left circumflex and the LAD. So you have these coronary arteries, okay, that basically fill up and distribute oxygen and other nutrients to the tissues of the heart. And if there are clogs, okay, if there is something blocking this is called atherosclerosis, right? If there's a plaque blocking it, it's called atherosclerosis. It's glorified plumbing. It is literally a pipe that is clogged, okay? That can cause issues, right? And this is it. We make it really difficult sounding. We make it very complicated sounding. It is literally a pipe going to your heart muscles, and how much of that is clogged. And there's 3 main pipes. That's it. That's most of heart disease right there, right? And this is my own tree that I made showing what I think are the most important factors, causing plaque. The biggest one is just your baseline plaque. If you have a high calcium score, you are very likely to progress that score to a high rate. The biggest risk factor that's known is hyperglycemia and insulin resistance. Okay, blood pressure is probably the second most important factor. I think inflammation and endothelial dysfunction are the third and fourth most important factors. And then there's atherogenic lipoproteins, and this is controversial, but we're talking about it, namely VLDL and remnant cholesterol, which are the most potent attackers of the blood vessel wall. Remnant cholesterols, really, really small, very, very low density lipoproteins. So, and how do you reverse plaque? Well, we're going to talk about this, and you will go through the data: exercise, reverse insulin resistance with a low-carb diet, lower your blood pressure with a low-carb diet, lower your VLDL remnants and small LDL with a low-carb diet, decrease inflammation, and in some cases, and we're going to talk about these, medications and supplements can also decrease and reverse plaque. So this is actually a video that I want you to all see. This is actually a advanced imaging. Do you see it down here? Pay attention down here. This is a 3D model of somebody's coronary arteries, and this is a test called the Cleerly test, and it is a CAT scan of the body with a little bit of dye. And what's happening here is we put that dye into the arteries, and then we measure the flow using AI and through the sections that we cut through to actually recreate your blood vessels in a 3D model to look at exactly the volume of plaque in each one of those arteries, okay, and each one of those areas of the heart. And you could see here the three main arteries I talked about. The right here is yellow, and then the LAD is here on the left side, or I guess it's left to you all, the left side. And then this one back here is the left circumflex, which usually wraps around the heart. Now, these are the three main arteries, and this test, the CCTA, the Cleerly test, which is an AI-enhanced, it's like a CAC, it's a CAT scan, that uses dye to look really closely and see what percentage of plaque or stenosis is present in the arteries. And I think that this is the future of medicine, is non-invasive imaging tests to determine the extent of disease. And this is a less than 20-minute exam. And you can see here, we're scrolling in and out inside that blood vessel, looking to see how patent it is and how much plaque there is. So it's a really, really cool test. And who should get this test? Should everybody get this test? Probably not. And you should talk to your doctor about who should get this test. This is one of the newest tests that I'm, actively looking into researching and ordering. And it's not for everybody. It's just like any test. It's the right case, right patient, right time. But it's a very informative test, and I think it'll be more and more common in the preventative space. So let's keep going here. So cardiovascular disease, it's basically a group of diseases: coronary disease, atherosclerosis, ischemic heart disease, peripheral disease, and this is the point of me sort of bringing up those maps. What is that common pathology? Is it metabolic syndrome causing insulin resistance, causing blood sugar fluctuations, causing vascular damage? Is that the most common cause of heart disease in our modern society? And I think it is. It is the number one cause of death in both men and women. Over 25% of deaths are from heart disease. And just in the 20 minutes you guys have heard me, maybe more than 50 people have died from heart disease. So this is a huge thing. And remarkably, this is so minimally screened compared to mammograms. Raise your hand if you're a female here in the audience or whatever, and if you get regular mammograms, like just give me like a perfect. Okay, everybody raise their hand. So now raise your hand if your family also. Give me a thumbs up if your family, gets regular colon screening or mammogram screening, breast cancer screening. Raise it. Okay. Now give me a thumb. Everybody raise their thumbs up. Everybody's giving me a thumbs up. Give me a thumbs up if your family members get CACs or Cleerly exams. Right? There's nobody raising hands, right? One or two people raising their hands, right? Not many. Right? And this shows you how few people are getting screened for the most potent killer. And if you want to know the reason why, is because, and to put it simply, modern medicine says, just take the meds, you don't need to know. That is literally the reason why. And your family didn't know this because the docs have authoritarianly decided you don't need to know, just take the meds, right? And I kid you not, I had this conversation with Steven Neeson 8 years ago. So this is the natural progression of atherosclerosis, right? You get this damage to the wall, and then, the body's trying to heal and repair that, and there's macrophages there. There's lipids getting stuck, and eventually it becomes a complete clog. And then when it's completely clogged and there's no blood able to get to that area, you're going to get dead tissue, and that's a heart attack. If it goes to the brain, it's a stroke. And if you're looking at it like from a pathologic perspective, this is kind of what it looks like. It's like swelling up at first, and then it's sort of stabilizing, and then it's creating its own inflammation and own problems because it's certainly not regressing. It's not getting better. There's also a bit of fluid dynamics there, because if something is going into the blood vessel wall, right? Remember, it's going to cause more pressure in that area that it is, right? And so it's sort of like, when you kink the hose, the garden hose, if you kink the hose, the speed goes up and the pressure across that area kind of increases. So the plaque itself becomes a cause of disease. And this is what it looks like. And this is a surgically removed plaque. It's like this rubbery, hard thing that is blocking an artery, and it's only a couple of millimeters thin. And this is actually an angiogram, right? This is the gold standard test where we put a catheter near your heart, and you can see we're injecting dye and looking at all the main arteries of the heart, and you can see, there's an main artery back here, another one that wraps around here, and then this one, which is stopping right here. The dye stops here, and this is a very potent occlusion. This is a heart attack happening, and this patient here got a stent placed. You could see the stent basically from here to here, and you can see the blood flow is reestablished in that area. You could see from here, no blood flow going down, and then you can see here there's now blood flow going down because the stent was placed. And so this is the importance of getting to heart disease early, because we have a chance to save that tissue. We have this saying, time is tissue. And I think this is why screening is so important. If we can get to it years before and know about it years before, we're not, being caught by surprise. The majority of atherosclerosis is just silent and develops without screening. And this is, I told you about this problem. It's your blood vessels are getting injury after injury. The lead that's in the paint in your home, the cadmium that's in your food, the pollution that you breathe in, the microplastics that are in our food supply, you can't really escape it, unfortunately. But then the ones that we cause on ourselves, which are probably the hyperglycemic excursions that are attacking our blood vessels, the blood pressure excursions from the stress and the weight, these are the things we can do something about. So all of these attack the blood vessels, and they silently get damaged for years. And ultimately, maybe you'll get a little bit of chest pain or short of breath, or maybe you'll get a little numbness, and then, the end stage would be a full-on heart attack or a stroke. And if you look at the risk factors, this is from the Women's Health Study, this is probably the most important thing you can look at, because your cardiologist, unfortunately, will focus on, ApoB or LDL, and you can see that these things matter for predicting, the heart disease. The hazard ratio here, which is like a marker of how important it is as a meaningful risk factor, clearly it is associated with risk, the total cholesterol and the LDL, but you could see how much more significant diabetes, metabolic syndrome, blood pressure, even physical inactivity matters more, in my opinion, and according to this data set, than your LDL, let's say. So for me, it's not that LDL is not important. I think in the metabolic space, we can get a little hyperbolic and say cholesterol is meaningless. And I don't think that that's an accurate statement. I think it's appropriate to look at cholesterol in the totality here and just know that there are so many more things important. If I reversed my diabetes, my metabolic syndrome, my hypertension, and I feel great, and I nominally increase my cholesterol, I'm happy with that trade-off. And the question is are you, based on this data? So it doesn't mean that LDL is not impactful. It just means that are you willing to accept the trade-off? Or do you want to brute force your way into a salad diet prescribed by an orthorexic cardiologist? Excuse me. Sorry. So when you're looking at disease, figure out what's in your control, right? And what's not in your control. Your age is probably the most potent risk factor. Family history, you can't control. Your genes, you can't control. But what can you control? Can you quit smoking? Can you reverse your diabetes? Can you reverse your obesity? And the answer to everything here is yes. And we're going to talk about physical activity today. And I'm so excited. If you're a guy or a girl out there or a gal out there, and you're thinking, what is the most important thing I can do? I want you to prevent, cardiovascular mortality. I want you to hear about cardiovascular disease. So that'll be coming up in a bit. So how do you diagnose these problems? I've already showed you some of them, right? You can do a vascular ultrasound, maybe a little carotid scan. You can do a CAC, a coronary artery calcium scan, which is a CAT scan of the heart. You can do an EKG stress test. You can nuclear stress test. And I've already given you a behind-the-scenes look at the coronary CTA, the CCTA, the Cleerly test. And the most invasive is the angiography, which is the gold standard, which I showed you a picture of already, which is a guide wire put in through your groin or through your wrist, going directly to your heart and looking at your heart in real time. So we're going to talk about what is a stress test. Remember, I told you it's glorified plumbing. Well, this stress test is glorified plumbing combined with glorified electrical work, okay? So it is glorified plumbing and glorified electrical work. What happens? If that plumbing is clogged, remember there's those three main arteries going to the heart. And if one of them is got a clog and you're stressing the heart, you're making that heart muscle work. It's going to need more oxygen. It's going to need to beat faster. And if it's not able to get blood flow through that clogged pipe, remember I said it's glorified plumbing, then what you're going to see is poor performance electrically. Because you're not getting enough oxygen, the electrical changes will happen during that stress test. So a stress test combines a functional test looking at the pipes and are they able to get blood flow through, and it's looking to see the outcome, which is the electrical activity preserved in a non-pathologic way? Is your electrical activity okay? Does it look like this on the left side, right? And if it does, your heart's good. It means it's functioning, right, when you stress it out. And if you see some changes on the EKG, it could mean that there's a blockage there, and you may opt at that point to do a more aggressive test. Now, cardiologists love to do this functional test. It's a nuclear stress test. It costs 10 times as much. And, if you've done a nuclear stress test, give me a thumbs up here. Give me a thumbs up if you've had a nuclear stress test. Nobody. Okay. Well, one person. Okay. So one or two people. So guys, this is a great way to make it's a good test. It's a great way to make your cardiologist very rich. They pass nuclear material through you. So don't sleep with the dog or the grandkids or the kids if you have this. And what we're looking for is to make sure that nuclear material distributes to all parts of the heart. And if it misses a part of the heart, it suggests there's a blockage there. And it's a slightly more accurate way of testing for a blockage than a traditional EKG. But most of my patients, I would not get this test. I would stick with a EKG stress or a stress echo, and I would rarely request a nuclear stress test. But it is one of the ways that you can evaluate the function of the heart. And now we're going into calcium scores, and you're going to learn more about this now. A calcium score is a CAT scan that's looking at the pipes of the heart, right? It's not nuclear material. It's not the electrical activity. It is literally just looking at the calcium. So it's looking at the calcium buildup, and this signifies damage and repair to the heart. It doesn't mean you had a heart attack. And it's a scanner like this. You go in and out, and it's looking at those heart arteries. And you can see here one of the heart arteries coming out of the aorta. And just to orient you, this is the back of somebody, and this is the front of somebody, and this is 4 different people, and it's measuring the amount of plaque in their LAD. Here in the LAD, here in that blood vessel, there's no calcium, right, and calcified plaque. And here in this scan, there's a little bit of calcium in that LAD, and you could see here there's more and more extensive calcium in this bottom right-hand corner. You can see extensive calcium in that LAD, also in the left circumflex, also what appears to be the right coronary cusp here. There is a bunch of calcium. So this is somebody with extensive disease, and this is somebody with no disease, right? And when I say disease, I mean calcified plaque. Oh, I didn't realize we were going to show it to you. This is orienting you and showing you all of these things. I forgot about these. So just know that like early plaques don't necessarily show up on a calcium scan. It may take 2 to 3 years of that damage to calcify the plaque, ongoing damage. And you may have soft or fibrous plaque that form earlier than that moment. So just I want you to know. And these calcium scans are often reported as a calcium score. So it's an actual score. And what's the downside of getting these scans? The downside, just like anything, any radiographic test, is some radiation. And just so you know, it has about 1 millisievert, maybe 2 millisieverts of radiation. And that's about 4 or 5 transatlantic flights. So it is a modest amount of radiation. It is radiation, but I would say quantify it. How would you feel, about traveling to London and back, a couple times throughout the year? That would be the extent of radiation. So I just want you to understand the fundamentals of the score, because a higher score does mean higher risk, but I want you to understand a little bit of nuance around that. I do want you to know that a 0 score means that your risk is very low, less, like under a 10% chance of having an issue. So it is a very much a de-risk. 0 score doesn't mean 0 risk. It does not mean that. It doesn't mean you have no chance, right? If you have 0 calcified plaque, if you were to take cocaine and your blood vessels were to clamp down, you still could get a heart attack. If you were to, inject lead into your arteries, you still could get a heart attack. If you were to inhale cadmium and go sleepless for nights, you still could get a heart attack. If you had an autoimmune flare and had a dissection of your coronary artery, like in Kawasaki disease, you could still get a heart attack. So a 0 score doesn't mean 0 risk. Remember, the heart disease is not one thing. It's a composite of damages. And calcium is a later finding, 1 to 2 years in. So it's something to understand. 0 score means low risk, not 0 risk. So, I had a family history of coronary disease in my family. Mother, father, grandfather died at a young age. So I got a scan at 30 and 35, and it was 0. And while it's true that my risk is low, and I got it at 40 as well, and it was 0, that's important, right? But a 45-year-old with a 0 score, well, the majority of people at 45 are going to have a 0 score. Only really sick people at 45 will have some calcium, right? The 90th percentile would be a calcium score of 36. The average 50 to 55-year-old male will have some calcium. So if you had a 0 score at 70 and you're a male, that's amazing, right? Even like a top 1%er may still have a score of like 5 or 10 at 70. So you have to understand that age is the biggest risk factor, and as you age, you're going to develop calcium. It does mean higher risk, but it's sort of like wrinkles and white hairs. You know it's coming, right? We all know it's coming, and we just accept it, right? So it does make your risk higher as you age, but you have to take the score into context. If I was 45 and had a score of 100, that is, yes, it's coming up, Jill. That is something to be concerned about. If you're 70 or if you're 75 and you have a score of 100, that's doing pretty good. So it's age dependent. I will get you all the score for women. I don't know if I have it in this presentation. I don't think I do, but it's actually basically 5 years older than men. So it's almost identical, but the average woman, okay, at somewhere between 55 and 60 will develop some calcium. So whatever you see for men here, just add 5 years, and that's what a typical female would look like. But I'll work on getting that female number added. The concept of this, because we're going to tell you how to, you can actually look up your own percentile. Just type in Google MESA percentile, MESA percentile, and you could get your calcium score with Torrent Health. Check your percentile. We'll actually go through it with you, and so you can we'll show you how to do that. But yeah, I should be more inclusive here and add a section for women. But the point here was not to talk about men and focus on men. It was just to make the point that the calcium score increases with age. So, this is actually taking a modeling, showing how a higher risk score increases your 10-year risk. So if you're 45 and you have a 0 score, your risk of having a heart attack may be like 2% in 10 years. If you have a score, or even a low score of 36, that number tripled, right? And you could see if you're 60 and you have a 0 score, gosh, you're not too different than that 45-year-old. It's like a 2% 10-year risk. But if it's 400 or 500, it's like a 10% chance of having heart disease. So the higher the score, really, that's what's driving the risk here. You could see, the score matters even more than age to some degree. So a higher calcium score means higher risk, and this is a great example because it shows, it shows how many events somebody has if they have a 0 score and 0 risk factors. If you have 0 score and 0 risk factors, the chance of you getting a cardiac event is very low. It's not 0, but it's very low. And you can see as you develop risk factors, hypertension, smoking, obesity, the risk goes up, right? You get more risk as you get more risk factors, but a 0 score is still very protective, right? Like there are not a lot of events that will happen in the next 5 years, even with those risk factors. But you could see when the score is high, those risk factors magnify. The extent of the disease, the probability of disease goes way up. So this is the importance, I think, when we're thinking about medications, interventions, and supplementation even, if you have a 0 score, you really can just focus on lifestyle. You don't have to treat numbers or, don't worry about that. Just go fix your life. Get from 3 risk factors to 0. But if your CAC is well over 100, okay, and you have multiple risk factors, your chance of having a heart attack in that year could be upwards of almost 30%. So in that case, you may want to consider being more aggressive with medications. And this, I think, is a tough when you're dealing with lifestyle medicine to convey this in a proper way, right? So if your risk is high, you may want to be more aggressive. If your risk is low, you may not want to be aggressive. You still can be if you want, but you may not want to be. And I think this is an important point for people, to drill home. Look at your personal risk. Don't look at your, sometimes we have these ideals or dogmatically hold to, I'm never going to do a medication. And I'm guilty of that. I don't want to go on medications. I don't want to put people on medications, but I think being, looking at the numbers with a clinical team that cares to, it puts things into context. Like maybe I should consider, baby aspirin, or maybe I should consider that nattokinase, or maybe I should consider a cholesterol medication or colchicine, or, we're going to talk about all those. This is a study that looks at the power of zero. If your CAC is zero, you can see, taking a statin versus not taking a statin, the cumulative incidence of events doesn't change much in a big data set that was published in JACC, which is a prominent journal. But if the score is, 1 to 100, you can see some benefit to medications. And if that score is high, you can see a much more bigger benefit shown, much decrease rate of incidence in the real world from taking a medication. So there is a right person to take medications. I think it's on the doctor and the patient to figure that out. So takeaways here: higher score means higher risk. Zero score means really low risk. And it doesn't mean no risk. It just means really low risk. How often should you repeat it? This is a question that I get asked all the time. Under a high risk scenario, I would repeat it 2-3 years, sometimes even 1 year. I think if it's zero and there's not a lot of risk factors, you can do it every 5 years. So like I did in myself. Again, there's no guidelines on this right now. I think it's a one and done according to the AHA, which is tragic. So what if your score is not zero? Well, okay, if it's not zero, the mission's the same. Bring your risk factors down, right? You can go from 28 to 10. That's an 18% reduction in events. Like, that's huge, right? That's really huge. So I think it's important to think about treating this, right? Treating it with respect. If you have calcium and risk factors, treating it with respect. And lifestyle matters most. You can see here, your insulin resistance, your triglycerides, like these are wildly important for developing heart disease and type 2 diabetes, metabolic syndrome, hypertension, and obesity. You can see these are all up here, right? So like, look at the hazard ratios here. They're huge. So, being low carb, being physically active, managing your stress, sleep, quitting smoking, these are vitally important. We're going to talk about all the things that decrease risk, or some of them that decrease plaque, and I'm going to go through some of this, including exercise. And even though some of them I may be, I may be hated, I'm still going to discuss it because nobody likes to talk about statins. So, look, atherosclerosis is dynamic. These plaques are dynamic. They're chronically changing at any given time. Like, it's not a static thing. They're developing, they're resorbing, they're going back, right? And multiple different modalities have been shown to regress or stabilize plaque. Exercise, lipid therapy, anti-inflammatory drugs, supplements, these all been shown to and we'll talk about it, to actually regress plaque or prevent plaque progression. And we're going to talk, like, majority of the studies I'm going to show you use CT angiography, which is that clearly test, that 3D sort of test that I showed you, or intravascular ultrasound, which I did not show you, but is looking inside with an ultrasound to see what's going on at the heart. And plaque is measured in a bunch of different ways. You see some tests, using this marker called percent atheroma volume. And this is basically using intravascular ultrasound. You see the amount of low attenuation plaque or calcified plaque and in millimeters cubed, as a volume metric. It's the CTA measurements. And then there's other ways, the CAC score I talked to you all about. And maybe you can even look at the thickness of the carotid. These are all different ways to measure plaque. But I want to get into exercise first, and I'm going to try to blow through this because it's been an hour already. I don't even know how an hour passed. But exercise probably improves, I'm going to show you the data on it, insulin resistance, endothelial function, inflammation, and blood pressure. It doesn't really do much to lower lipids. This was a study looking at high-intensity interval training, 3 minutes intense, 3 minutes zone 2, or 4 minutes intense, 4 minutes zone 2, and it reduced percent atheroma volume by 1.2%. So you can actually regress plaque, okay, with exercise, right? Now, that's something to note. This is the total plaque volume. Exercise is associated with increasing calcification, most likely because those plaques are stabilizing, but the volume is decreasing. Exercise literally shrinks plaque. And there's studies going back 30 years that showed that, where they took people and put them into cardiac rehab programs, and they showed that the people who had a high exercise dose actually slowed the progression of their plaques using angiography versus those who did not exercise. And there's 6-month programs done more recently showing that literally these plaques are shrinking, and it's most likely associated with the reduction in inflammation. So this is this is a summary of all the different modalities that we've seen that have affected plaque. We summarize it. It's on the app. You can take a look at it. Basically, the bottom line is several different exercise modalities reduce plaque. Go exercise, cardiovascular, high intensity, weights. Go do it. 8 hours a week. Do it. There's a risk to that, actually. I should tell you. There's a risk of exercise is, mechanical injury, right? Or mechanical fall, orthopedic injury. So there's always risks to everything, including statins and exercise. And EPA, the risk of an EPA, taking omega-3, there's a slight increased risk of atrial fibrillation. So how do omega-3s work in the EPA? Probably the same way. Endothelial dysfunction, inflammation, blood pressure, but they also reduce remnants and VLDL. They reduce triglycerides. And this is the EVAPORATE study in 2020 where they showed that using CCTAs, that fish oil, prescription grade fish oil, can reduce soft plaques by 20%. And this had nothing to do with cholesterol. It had to do with the EPA and its inflammatory and plaque stabilizing properties. And this is the study of people on Vascepa versus placebo, and the people on Vascepa had less cardiovascular death and less plaque volume. This is all in the app. You can check it out in the app, in the CAC and cardiovascular course. We get asked this all the time, K2 and D3, and always add MAG to that. Supplementation has been shown to prevent plaque progression, most likely because of its impact on endothelial function and inflammation. The AVIDEC trial was a study looking at K2 at a fairly high dose. You want over 400 mics in a population that had a CAC over 400, and those who took it had slowed coronary calcium progression. So I think it's a relatively low risk. There's no cardiovascular outcomes data with this, but it's a low risk supplement that seems to have a positive impact. Nobody knows because nobody's studied the supplement for outcomes, or you could just eat liver and call it a day. But it does at the least seem to prevent calcifications, which are associated with worse outcomes. Nattokinase is hot. Give me a thumbs up if you've heard of nattokinase. It probably works by degrading fibrin and improving endothelial function, also improving inflammation. It may have a slight impact on lipids. And the reason why it's hot is because it lowers the carotid plaques in a study of about 1,000 people. This was a retrospective study. So just realize that this is also no long-term evidence that it reduces events, cardiovascular disease, but it does seem to reduce plaque size and thickness on carotid ultrasound. No idea if it improves mortality, improves cardiovascular deaths, or even prevents heart attacks. We don't know. But it is an enzyme found in natto, which is fermented soy. So presumably it has thousands of years of adverse events monitoring, right? So real world adverse events monitoring. I'm not saying that's solid data, but I'm just letting you know why people take this. Colchicine is another drug. This is a 1,000-year-old medication, been used for gout for 1,000 years, and it's been shown to stabilize plaque and by improving endothelial function and inflammation. A low dose of colchicine has been shown to reduce the percent atheroma volume by about 1%, probably because it blocks that inflammatory cascade. There's 4 classes of cholesterol-lowering drugs. that have been shown to decrease plaques, and some of them have been shown to decrease cardiovascular mortality, and some have been shown to reduce all-cause mortality, most likely because they improve inflammation in some cases, and also most likely because of their effect on remnants and small LDLs and VLDLs. Many of them worsen insulin resistance, so it's just something to know. Many people report, just not feeling well on them. They're actually, the statins are a mitochondrial inhibitor. So don't shoot the messenger. They're widely overprescribed, in my opinion, but there may be cases where it's important to consider them at the least. But just so you know, even the most potent LDL lowering drugs, like the PCSK9 inhibitors, they failed to show a mortality reduction even after dosing thousands of people for over 5 or 7 years. There was no mortality reduction that was statistically significant, anomaly significant. And like I said, there are some issues that are reported. So just talk to your doc. And this is a joke. If any of you know who Dr. Dave Diamond is, he's a friend of mine. I look up to him. He's a really a maverick and a loud voice in the space. And, he's been very vocal against statin use. So this is doctors talking about statins like myself right now, running away from David Diamond. Give me a thumbs up if anybody got my joke here. But these are all the trial results that, here's a different class of drugs that have been shown to reduce plaque. Ezetimibe is a cholesterol-lowering drug. It's a non-statin. It's been shown to reduce plaques in patients with diabetes, and it lowers cholesterol mainly through preventing absorption. PCSK9 inhibitors have been shown to reduce plaques, but like I said, they did not reduce cardiovascular mortality or all-cause mortality. And there's been several trials showing that statins also decrease plaques, but as I said, they also have some adverse events, a high rate of adverse events. So we talked about the power of zero, so I'm not going to stay on it. We talked about the Zetia and the LDL lowering. If you line up some of the statin and Zetia trials, and you sort of it appears that there's a linear relationship. Yeah, Repatha is Evoluca. We discussed that. It's Repatha is the PCSK9 inhibitor. It has been shown to lower plaque size, but it has not been shown to reduce cardiovascular mortality or all-cause mortality in a statistically significant and nominally significant way. So just something to note. It did lower cholesterol really well. And there was a re-adjudication that looked pretty ugly, meaning independent doctors looked at it, published the deaths that they saw after a reanalysis in the BMJ, and said it's even worse than the trials looked. So you can look up at the BMJ re-adjudication of Repatha. So let's wrap it up here because it's been way too long, and my family is like, where the hell are you? What drives plaque regression? Lowering blood pressure, decreasing insulin resistance, that's first line. Low carb diet, exercise. Exercise improves endothelial function. It's been shown to regress plaques. You can consider anti-inflammatory therapies. You can consider omega-3, K2 and D3. You consider VLDL and remnant lowering medications, cholesterol lowering medications. These are all considerations you can make with your medical team. I'm here to bring you the data. You got to go back to your doctors and have discussions with them. So the clinical takeaways, basically, lifestyle is most important and paramount. Inflammation is an independent way to lower plaque. Exercise is irreplaceable. Plaque reversal is achievable. Not calcification, but plaque volume is reversible. Plaque is a reversible condition, and there's multiple pathways that you can use to reverse plaque. And I just want you to know that there's a lot of limitations here. Most trials are just looking at really sick people. Imaging endpoints do not mean clinical endpoints or mortality reduction. So just because the plaque's reduced doesn't mean you won't die more often, right? There's a lot of issues when it comes to recommending a chronic medication. When you take a chronic medication, you may get chronic adverse events, so it's always worth considering, what those adverse events may look like. Bottom line is this, lifestyle matters most. Do low carb, be physically active, manage your stress, sleep, quit smoking. And a 0 score means low risk, not no risk. And maybe repeat it every 3 to 5 years, depending on your, clinical situation. And I'll pretty much stop there. We need to do better. This is our heart disease map. It's gotten even worse than 10 years ago, and we need to do better. Just putting it out there because I have to plug myself a little bit. If you're not a patient or you have somebody who's not a patient of Toward Health, it's a family member, and you want to get them a CAC or you want to get them key metabolic labs, we have a really low-cost way, and I'm going to put this in the chat here. It's toward.health/screenings. Okay, it's a very low-cost way to get you or your family low-cost screenings. We are able to get nationwide discounts on labs and CACs. So for about $400, you could get a CAC anywhere in the country, from Manhattan to San Francisco, and you can get labs and a doc to review it with you, and our amazing curriculum on our app. So a really convenient nationwide way to get screened. And I'm going to stop it there and just maybe open it up to questions and see what you all think. Hopefully you all found that helpful. Yes, by the way, this will be shared on the app. So yeah, absolutely, this is something that will be shared. So it'll be posted on the app literally in a couple of minutes. So absolutely. Yeah, hopefully you found this. Hopefully there was enough new information here, because it's always nice to see the people who come to everything. I love it. But it's great to see new faces too. So hopefully you guys like this. Hopefully, there's going to be a lot more of this. Guys, please recommend the Toward Health screening, the Heart Scan or Heart Scan Plus to you, your family members, anybody who wants it. You really can't get a lower cost offering. We got crazy pricing. We pass off that savings to you all. I mean, imagine getting 40 lab tests and a CAC for about $400. It's so cheap. We literally can't do better. I don't think you can do better anywhere in the country, to be honest. And then also, another thing, come support Tia and Vic. They have a great fasting support group. By the way, fasting has been shown to improve heart function and heart failure by 15%. So it's been shown, literally intermittent fasting has been shown to improve heart function by 15%. So really dig down on intermittent fasting this month and use the resources from Vic and Tia. You guys, appreciate you all, and if there's no questions, I think that'll be it. I'll wait like a couple minutes for some questions and then, leave it at that. All right, guys. Yeah, you're welcome. You're welcome to everybody. Thanks for joining. Tom had a question. Maybe I missed it. Tom, type your question in the app, in the chat. Can somebody just retype the question? Plaque can be reduced. Okay. So here's the question, guys. I'm going to read it out loud. Okay. The question here is, plaque can be reduced, but calcification cannot. I have seen calcium reduce, but I'm not sure if it's a reading error. Because it's 2.5 millimeter cuts. So we cannot, I cannot say that the calcification has decreased. I've seen patients maintain a calcium score for decades. Okay, so I've seen that. The only time I've seen a score decrease is because I think the cuts were a little bit off, and so It could be plus or minus 20 or 30%. So I think that's an issue when you're talking about plaque decrease. I think the test of time is showing a stable calcium across many years. That is a very robust signal. There's some anecdotal data of calcium regression, and every time I have looked at those images, I have not seen it. Like it was an error, meaning like the 0 score was when the heart wasn't in the frame. It's clear that K2 halts may regress some plaque. It possibly, some data look like it regressed some calcium, but it's tough to tell because 2.5 millimeter cuts can create some variability. Without any certainty, with 100% certainty, we know we can decrease the plaque volume, right? And that's probably most likely the soft and fibrofatty plaque that's not calcified. So the average rate of progression of calcium is 20%. So if you can keep your calcified plaque stable, you're winning. Hopefully that's answering the question. Yeah. So, so here's some questions that I can ask. So what about alcohol? Yeah, it's unclear. Actually, alcohol is a platelet inhibitor. So it's a platelet inhibitor. So if you had a high calcium, there's a slight possibility it could inhibit platelets, but it causes insulin resistance. I wouldn't do alcohol. I wouldn't do alcohol. But, there's a case to be made of moderate alcohol consumption inhibiting platelets. But, there's other ways to inhibit platelets. So I don't think there's any strong data. Clearly and HeartFlow are basically that they both use AI to assess the CCTA. So the question is what's the difference between Clearly and HeartFlow? They look at different things. HeartFlow basically looks at the fractional flow reserve. It's a very specific metric, and they don't have the degree of stenosis data, like data on the actual caliber of the disease. So unless they've changed in the past couple months. So I predominantly use Clearly. Some institutions use HeartFlow. They both cost about the same now. Let's see. Question here is about, do I think that the CAC being a covered screen, do I think that's going to change? Well, it's already recommended in the AHA guidelines. And when insurance decides to cover it, I don't know. But in the meantime, we can get it for you at Toward Health at ridiculously cheap. So the CCTA will be covered in select cases if you were to have some symptoms, atypical chest pain or shortness of breath. So if you have the atypical chest pain or shortness of breath on exertion, if you're huffing and puffing on that Stairmaster, then you could qualify for it. I think you just got to talk to your doctor. So there's a question here, and I can't give personal medical advice, but they said there's a spinal stroke, and then they got a CAC. Spinal stroke, I'm so sorry, Kit. They could certainly be related. They definitely could be related, and it's a sign that you had that CAC score of 620 implies you've had disease for maybe 2 decades. So you had known atherosclerotic disease for probably, based on the test you got, for at least 5 to 10 years with a score like that. I'm gonna punt on the cayenne pepper supplements. I don't know enough about it. There is some interesting data on like the nitric oxide effects of caspasacin, but I got to go back and look into the data. there's some data on like plaque reduction in like pomegranate juice and caspsaicin in the carotids, but it's not as robust as what I shared with you. As far like, I'm happy to re-review data, but I haven't been impressed by it. All right, guys, it's an hour and a half, so please download the Toward Health app if you're coming in on social, and if you're not on social, or if you're on social, go to toward.health/screenings, and we'll get you screened. And if you're a family member, guys, you know, we got Laura and we have Mary, and they are amazing people, and we are just chomping at our bit to be able to screen people. And you know, really our effort here is, we know we reduce cardiovascular risk. We did what the AHA wanted. So we're hoping to find people with that early cardiac disease, like the person who had a score of 620 and just found out this year, and then getting them ridiculously healthy and protecting them, you know, by improving their lifestyle and considering some of the interventions we did. So share it with somebody, guys, because this is, you know, we're trying to, help, and we need your all help. So, and we need you guys to, you know, to value us, so we can keep doing this stuff. And I appreciate you all. All right, have a good night.